Moving on, I'll be going ahead with my talk. Can we have the screen, please? Yeah, I'm Shweta from Shankar Nethralaya, Chennai, and I'll be taking you through my learnings of Fornix reconstruction. Well, first and foremost, the approach of reconstructing the Fornix depends upon multiple factors. To start with, the underlying cause, whether we are dealing with something which is immune-mediated or non-immune mediated. So in patients like cicatricial pemphigoid or SJS, there are multiple other factors which need to be taken care of vis-a-vis a patient with a chemical injury. Whether the Fornix is progressive or stable, what is the aim of our intervention? Whether we are looking at visual rehabilitation or are we looking only at a cosmetic outcome? Was there any previous intervention done? And what about the surface inflammation? How inflamed or quiet is the surface? Now, what is the basis of choosing the tissue substitute? So where do I use an amniotic or a conjunctival autograft or a mucous membrane graft? Now, basically, it all depends upon the extent of the raw bed that is left behind after the surgical excision. So if it's only the palpebral surface which is left bare to cover, then you will go ahead with an amniotic membrane graft. However, if it is the bulbar and the palpebral which is bare, you will go ahead with a conjunctival autograft, sometimes along with an amniotic membrane transplant and with an anchoring suture. However, if it's the entire tarsal, palpebral and the bulbar surface which is raw, then you would prefer a mucous membrane graft along with an amniotic transplant and an anchoring suture to keep the surfaces away from each other. Now let me take you through this animated video of Fornix reconstruction, which was done by one of our cornea alumni, Madhuvanti. The basic principles are, it deals with, sorry. So the basic steps when we consider is the fibrovascular excision. Now when you're starting the dissection of a symblepharon release, the most important is to try and attempt as much of epithelized surface that you have. So instead of dissecting the symblepharon from the limbus, you start it from the apex so that that entire epithelized conjunctiva gets salvaged. Keep separating the symblepharon or the fibrovascular tissue from the underlying episclera. You might have to make relaxing cuts or nicks in the conjunctiva. Release all your fibrovascular adhesions and make sure that the globe is entirely mobile and it's free. Sometimes you also have to use mitomycin C in these patients. Either a 0.02 or a 0.04 is something that is advised. You can place it from 1 minute to 5 minutes. And once you have placed the swab, just make sure that it's not on the bare sclera. It's in the space between the conjunctiva and the tenons, and you give a thorough wash. Now let me take you through a few case scenarios to understand how we deal with these different grades differently. Now to start with, in a chemical injury with a grade 1 to 2 symblepharon, as was done for this patient who primarily wanted a cosmetic outcome. This was a grade 1 or 2 symblepharon that we were dealing with a corneal scar. So the plan was to release the symblepharon along with an amniotic graft and a conjunctival autograft followed by a tattooing. Now you assess the extent of the symblepharon, start finding your plane and start releasing the conjunctiva from the underlying episclera. Make sure that you dissect it well and keep following the plane. It's very similar to the small incision cataract surgery where you try not to change your plane. So just release all your fibrovascular adhesions, make relaxing cuts. The adhesions are released enough for a free motility. Now this is the same conjunctiva which we had released from the cornea. So if you see, because we salvage that, we really don't need a tissue substitute on the upper lid. And this is the same thing which was, we used glue and just ironed it out completely. Then the Fornix forming suture, it is usually taken with the help of a 5-0-proline. And then cover the bare bulbar surface along with the cornea with an amniotic membrane using a fibrin glue. It's important to iron it out evenly and smoothly without having any folds of the amniotic membrane. So you can use either a muscle hook or you can use a forceps. cut off the excess amniotic membrane. Just like in a pterygium, harvest a free conjunctival autograft, a thin one, and that can be used over the amniotic to again facilitate epithelialization and prevent recurrence. And this donor area can be covered with an amniotic membrane. We place a bandage contact lens at the end to keep the raw surfaces away, and a tarsorrhaphy to keep it intact. Now moving on to a grade 4 symblepharon, which is a little severe, you prefer again to have a Fornix reconstruction done in a graded manner. So in this child, we decided to form the inferior Fornix first, followed by the superior Fornix. So again, to salvage the amount of conjunctiva that you have, you start releasing it from the inferior Fornix. You identify the plane, dissect it completely. Now again, while dissection, you need to make sure that you don't bare the sclera. So there should be some amount of tenons which is left behind, otherwise it'll become like one ischemic sclera that you have left behind. So a thin layer of tenons can be left. Just you need to make sure that the adhesions are released well. Assess the amount of raw surface. Now in this case, because the tarsal plate was bare, we decided to use a mucous membrane graft, which was harvested from the lower lip. The size is based upon the raw bed that you have measured on the tarsal plate. You can use either a 15 number blade or a conjunctival scissor to harvest the graft. Close it with a 5-0 vicryl, and this is again a very important step where you're trimming the mucosa, making sure that it is really thin, and then anchor it with an interlocking continuous sutures using either a 7-0 or 8-0 vicryl at one edge, and the posterior edge is anchored with fibrin glue. Iron it well, stretch it properly, and then let it adhere to the surface. Now, Fornix forming suture, as I have shown here, that is the crease of the Fornix that you see, and that is where the entire depth of the Fornix is. So your Fornix forming suture has to pass at that level, and you can use either a 5-0 proline suture. A bolster is placed to prevent cut through of that suture. The other end of this proline suture can be passed through a cutting needle to form the Fornix. You can use either one Fornix forming suture or two based upon the extent of the release that you have done. And then the bare surface is covered with amniotic membrane. Now here we are placing a confirmer because the cornea underlying is scarred and vascularized. So a confirmer will give you a better Fornix reconstructive space, and then followed by a tarsorrhaphy. Similarly, this was another patient of a grade 4 symblepharon where we have gone ahead with a Fornix reconstruction. This was an 8-year-old child who presented with a near total ankyloblepharon. So the plan was to do a symblepharon release, amniotic transplant, and a mucous membrane graft like we did in the earlier patient. Now when we started dissecting it, there was a good amount of the conjunctiva as we dissected, which we realized could take care of the tarsal and the palpebral conjunctiva completely. So after excising the pannus from the cornea, since we realized that the Fornix was well formed and the entire tarsal and almost the palpebral surface was epithelialized, we just took Fornix forming sutures like we showed in the last video using a 5-0 proline. And since this was a large conjunctival defect along with a corneal, near total corneal defect, we have placed an amniotic membrane over the entire bulbar surface and harvested an AIOS to facilitate epithelialization instead of the conjunctival autograft. Since there is no limit to the amount of cadaveric tissue that you can use, for a conjunctival autograft from the other eye, we are still restricted to the size of the graft that can be used. So the AIOS bits were placed on the surface, anchored with fibrin glue, followed by a bandage contact lens and a tarsorrhaphy. So here, if you see, the initial plan was a symblepharon release with amniotic and mucous membrane graft, but we changed the plan. Since both upper and lower lids had good residual conjunctiva, we deferred the mucosal graft. Since a very large conjunctival graft would be required, we replaced it by using an AIOS. This is how the patient was 2 months following the surface reconstruction, early recurrence of the inferior Fornix, which was taken care of by a conjunctival limbal autograft. Now, when we move on to immune-mediated disorders like OCP and SJS, like was this patient, a 65-year-old known case of OCP, who was awaiting a cataract surgery. Now, like Dr. Arif brought forth the importance of taking care of the underlying ocular surface disorder. So in this patient, she had a symblepharon active inflammation. Eye was moist. We first started her on immunosuppressive therapy, that was mycophenolate mofetil along with oral steroids. 3 months later, once the eye quietened down, we formed the Fornix. 3 months again, 2 months later, following that, she was taken up for cataract surgery. Both the surgical interventions were done under immunosuppressive therapy. In SJS, the situation is a little different. Since it is a chronic stage in when we are doing a Fornix reconstruction, you really don't need immunosuppressive therapy. Here, in this patient, Fornix reconstruction was done to place a PROS lens because her vision after PROS was increasing to 618 from 6 by 60. In an SJS, a shortened Fornix is good because it reduces the area of exposure that is available. So make sure that you know the reason why you're reconstructing a Fornix in a patient of SJS, like was for this patient for the insertion of a Boston's clear lens. Otherwise, a surgical technique for Fornix reconstruction is no different from the way that we saw in the earlier cases of chemical injury. So my 7 learnings were, the approach has to be based on the underlying etiology and the indication. Tear status is one of the most important prognostic factors. Choice of the tissue substitute, that is amniotic, conjunctival autograft, or MMG, basically depends on the extent of the raw bed that we have created. We have realized that delayed epithelialization is one of the major reasons for a higher recurrence rate, and therefore we prefer a staged approach. Fornix forming sutures, confirmer, or a large bandage contact lens is recommended because it keeps the raw surfaces away from each other and prevents a recurrence. And counseling, again, like any other surgery, forms an extremely important aspect of Fornix reconstruction as well. For more videos on ocular surface surgeries, you're most welcome to explore our Ocular Surface Gurukul, a YouTube channel which gives you different nuances, explains nuances of ocular surface disorders and surgeries. Thank you so much.
Thank you to the chairman of the session. Wonderful talk. I have a small question. When do you decide to use or not to use mitomycin C in these cases?
Yeah, so actually that's a very, very important question. The thing, it depends upon the amount of scarring that we are seeing. If there is extensive scarring, extensive adhesions, then using mitomycin C plays a role. Otherwise, if it is not too much, then we can get away with that. So a 0.02 or a 0.04 for around 2 to 3 minutes with a good thorough wash.
Chemical injury and the parents or the patients are very pushy. They'll come and even within 1 or 2 months post-injury, they will say, I have a symplepharon, do some surgery, make it normal. I think it's important that you wait for the surface activity to quieten down, because if you hurry up and intervene to try and reconstruct, you will have recurrence and you'll have failure. So we always treat and we explain to the patient that we will not get many opportunities to do the reconstructive surgery. So if you intervene too many times, the prognosis will be bad. So at least wait 6 months to 1 year before all the, the inflammatory activity has quietened down. And then if you proceed with the surgery, you will find that the dissection also will be easier, the bleeding may be a little less. And post-op, the recurrence of the symplepharon chances also will be much less.
I think that's a very, very valid point. Quietening of the eye and the inflammation under control is a very important factor.
Yeah, and also we should know when not to intervene. Like if you have a patient with OCP and has a cataract, and if you diagnose that there is OCP, but you have significant clear cornea to do your cataract surgery, the only difficulty is you sometimes cannot put in a speculum, because if you try to put in a speculum, it stretches the conjunctiva, and then, so in those cases, take lid sutures, Just take lid sutures and do your surgery. So the minimal amount of conjunctival manipulation that you do, you can still do your cataract surgery effectively. But if you try to release symplepharon in all those kind of cases, it actually makes it worse. So I think taking a decision when to do a symplepharon release is also very important.
True. Any other questions?
And there is a limit up to what you can do. I have had a patient who had a very bad chemical injury. I reconstructed his surface, but every time he would come, vision is improved to 20/40. Everything looks much better than before, but he's always comparing with the other eye. No, when I do this, I can see a little bit more adhesion there. Can you release that as well? So don't get swayed by that. Know your limits and know when to stop.
Yeah. Any other questions from the audience?
One point, as was the point noted by sir as well, that the quietening of surface is important. As in the acute SJS case where you were showing,
It was chronic
it was
SJS.
chronic. Okay, so which is the choice of topical steroid it would be to quieten the surface along with the oral immunosuppressant? It would be the low potency steroids or dexamethasone or prednisone?
So, Nikhil, in Steven-Johnson syndrome, we are not touching the eye in the acute stage. Even in the chronic stage, we are very happy having a short fornix because a shortened fornix means a reduced available surface for the tears to dry. So the only reason that you do a fornix reconstruction in Steven-Johnson syndrome is suppose you're planning a cataract surgery and you cannot do a cataract surgery without intervening for fornix, or you want to insert a Boston scleral lens or a Prose lens and the symboliferon band is interfering with that. Because a shortened fornix is good for eyes with Steven-Johnson syndrome where most of the time the surface is very dry, your Schirmer's is very low. In this patient was a case of a chronic Steven-Johnson syndrome, SJS some 5-6 years back, and we were trying to insert a Boston scleral lens. With the Boston scleral lens, her vision was improving from 660 to 618. So that was the reason that we were doing it. So in those cases, you don't really need any oral immunosuppressive therapy because we are dealing with a chronic SJS. In that case, any topical steroid like we use for the others, a dexamethasone is good enough.
And the OCP case, the other one which
OCP
is
patient, yes. In all patients with ocular cicatricial pemphigoid, because there is an ongoing inflammation or any insult to the conjunctiva can stimulate an inflammation, you always want to do it under the oral immunosuppressive cover.
And
So
choice of topicals there?
topical does not really have too much of a role. You can go ahead with your normal dexamethasone that you use for all cases. The main thing over there is your systemic immunosuppressive therapy, and make sure the eye is absolutely quiet, the disease is quiet before you go and intervene. It could be 3 months, it could be 6 months. You might have to step up your immunosuppressive therapy to make sure that the OCP is under control before you touch the eye.